Professor Dr. Vivek Gupta, cardiologist, Delhi Apollo Hospital. Good morning to everybody. Today is 16th April 2026. I am going to talk during next 5 minutes about transcatheter aortic valve implantation. This topic is very close to my heart because I worked with Alan Crebier during the time of its innovation. There are a few pictures. You can see Alan Crebier, who is the father of TAVI, on the left. Then this was the interview which I took with him in hotel in Kolkata. This was when he was driving a car and I was sitting with him. And of course, he's a man of par excellence during one of the ESC meeting. And there are several such photographs with him because I worked with him in 96 to 98. TAVI is a non-surgical technique which is giving lives to many thousands and lakhs of people all over the world. And this was the innovation and idea and hypothesis initially of Professor Alan Crebier, who did the first case on 16th April 2002 in Charles Nicolle Hospital, Rouen, where I used to work around 1996 to 98. So in the next few minutes I will tell you what is TAVI and how it is really helpful to the patients. TAVI is a surgical technique, TAVI is a non-surgical technique which has almost replaced the surgical technique of surgical aortic valve replacement, which requires opening the chest and which requires also opening the heart and placing an artificial valve at the site of previously stenosed valve. What is aortic stenosis? I am going to tell you what is actually aortic stenosis. This is a small animation which I want to show you. This is that how the TAVI procedure is done. But we have another video which I will show you about what is actually the valve, how the valve is actually get stenosed, and you have a problem, the patient has a problem of pumping the blood through this. So this is a small video which I want to show you here, how the aortic valve stenosis actually gets placed. So this is transcatheter aortic valve implantation.
Transcatheter aortic valve replacement, or TAVR.
So this is how the heart is pumping the blood, and the blood is going into the aortic valve. So this is a small animation which shows, and this is, we are going to show you the aortic valve from inside. The aortic valve is a tri-leaflet valve, and the left ventricle is pushing the blood from that tri-leaflet valve into the aorta and to the rest of the body. So actually the heart is pumping the blood to the whole body through the aorta and through the aortic valve. So this is the aortic valve, and you see the normal functioning of the aortic valve. This is the normal functioning, opening the valve and allowing only one directional flow from the left ventricle to the aorta, and then you see slowly it gets calcific aortic valve stenosis, and you can see now the opening is restricted. This is severe aortic valve stenosis. So severe narrowed opening, you can see this is narrowed opening, and severe aortic valve stenosis leads to severe heart failure, and the heart has to pump a lot, and the heart gets diseased, thickened left ventricle, and this can lead to arrhythmias, and patient can have sudden cardiac death. So I will now show you how the animation, the work of how this actually the transcatheter aortic valve implantation does take place. So transcatheter aortic valve implantation requires putting a catheter from the groin, which is femoral artery, and then pushing the catheter from the groin to the descending aorta, to the ascending aorta, into the aortic valve, and then into the aortic valve. We have to inflate a balloon to create a passage, and then put the artificial valve which was designed initially by Dr. Alan Crebier. So next video, this is the video of this was showing how this takes place. So you can see that there is a catheter system which is pushing the balloon. It's a long balloon which is about 20 to 23 millimeter or 25 millimeter depending upon the valve, and it is reaching the aortic valve. You can see it is reaching, and now the balloon is inflated so that the space is created, and then the balloon is removed. So and there is always a sort of a catheter, stiff guide wire, which is there going from the groin and of course through the aortic valve. Now the stent is coming up. This stent which is a balloon expandable stent, and at the mid of aorta we have to do a sort of a positioning of the nose cone so that now it is prepared to go inside the aortic valve. So this is how the positioning takes place, and then we'll push the whole catheter into the aortic valve. This is the aortic valve. It is now going from the descending aorta into the arch of aorta, as I told you, into the arch of aorta very slowly, because this is a little robust catheter, and therefore you cannot injure the rest of the aorta. And then slowly you have to put it across the aortic valve. The heart is beating already, and we start doing a rapid pacing, and with the rapid pacing on, we will inflate the valve and inflate the balloon. And then after, this is very important, because you have to see very clearly the positioning, 2/3 here and 1/3 up. So this positioning is very important, because the coronary arteries are coming up here and you cannot occlude the coronary artery. So 2/3, 1/3 formula, and then of course you check with the calcium. Balloon is going up and the catheter is getting placed. The valve structure, which is a stainless steel structure, along with the valve inside, is left behind, and the balloon comes back with the help of catheter, which is removed, and then the groin is sealed. So this is the procedure of total transcatheter aortic valve implantation. We give actually big hats off to the person who did for the first time. And when he did for the first time, now you can see the valve, it is placed here without opening the chest, without opening the heart, and it's a tri-leaflet valve which is made from bovine pericardium, and there is stainless steel structure all through. So this is actually the procedure of transcatheter aortic valve implantation. So transcatheter means going through the catheter, transcatheter. Aortic valve implantation, putting a new artificial valve at the location, same location where there is a diseased stenosed valve. So when the stenosed valve, and then you have another valve which opens up, so now the diseased valve is set aside, and you have a valve which is an artificial valve of bovine pericardium on a stainless steel frame. So I want to tell you that this was not easy to do the first case. I used to work with Alan Crebier, and he was always all the time thinking about this. Of course, he was doing his coronary work, he was doing his administrative work, he was actually the head of department at that time in Charles Nicolle Hospital in Rouen in France. And when he was designing it, he had a huge problems, because he had to have a supporting company, and there was no major company which supported him. And for example, the valve, artificial valve, surgical valve, which was being sold by Edward Company, they refused the idea. They said there's something crazy and not possible to do it. Just forget it. So this was the sort of a reply which came from these big companies. Then he made his own company with Martin Leon. It was registered in USA, in New York, and then with the Israeli engineer, the engineers were Israeli, he had made a prototype, and this prototype was initially used in the animals. And when he did the first case, it was planned, or sort of unplanned case, which was a patient of cardiogenic shock. Patient had a blood pressure of 50 to 60. He was a post-bypass patient. He was 57-year-old only, young man, who was almost dying, and surgeons had declined to take it up. So he took the big challenge, and he did because the femoral artery was also occluded, iliac arteries was also occluded. Therefore, he had to do from femoral vein. He was a master of transeptal puncture also. He was a very great operator. And this is what Martin Leon told me, that since he was such an excellent operator, he could do it in a very patient who was really very sick patient. Almost there was a possibility of death on the table. So he did from the femoral vein, went to the inferior vena cava, from right atrium into the left atrium. Any cardiologist will understand how difficult it is, from going from inferior vena cava to right atrium to left atrium, and then from left atrium to left ventricle through the mitral valve, and then putting the wire across through the ventricle, left ventricle, into the aorta. It was a reverse direction. It was a sort of it is known as anti-grade approach. The approach where the blood normally takes this direction, that's known as anti-grade approach. And then in the reverse direction, he took the valve in the same balloon, and then the valve, which I have showed you, is a retrograde approach, which goes from the femoral artery. So he did the first case accidentally, because there was no possibility to have a femoral artery puncture. So I really give a big salute to the man who did the first time. I have already explained how the transcatheter aortic valve implantation takes place, and we are doing it regularly in Apollo Hospital. So please do visit Apollo Hospital in case you require. And you can meet me, Dr. Professor Vivek Gupta, in cardiologist in Delhi, Apollo Hospital. From 2002, the first case in India, it took about 12 years, or 2014 or 15, it just was started available. We did our first case. The first case of transcatheter aortic valve implantation from India was done by me in France with Alan Crebier in November 2011. So I am very proud to say that the first case was from Delhi, from Apollo Hospital, my patient who flew from India to France, and we did the first case in November 2011. Thank you, Dr. Gupta from Apollo Hospital on 16th April, talking about TAVI. Thank you very much. Bye-bye.